Glomerular diseases. Although many different diseases act on the glomeruli, the effects of glomerular damage are limited and include the following: reduced glomerular filtration, proteinuria and hematuria, hypertension, sodium retention causing edema. Glomerular disease can seem confusing, partly because it can be classified according to clinical features, histopathological appearance, or the underlying disease process. Glomerular disease can affect one or more of the components of the glomerulus. Glomerular basement membrane, glomerular cells, intraglomerular vessels, mesangium. Important pathological terms that describe the histopathological appearances include the following: proliferative disease, there is proliferation of cells within the glomerulus. In severe cases, proliferation of cells, especially macrophages within Bowman's capsule, causes an appearance known as a crescent. Mesangial disease, there is excess production of mesangial matrix. Membranous disease, the glomerular basement membrane is damaged and thickened. Membranoproliferative disease, there is both thickening of the glomerular basement membrane and cellular proliferation, usually of mesangial cells. The pattern of glomerular involvement is further classified on the basis of whether all glomeruli are involved, and whether the whole of each glomerulus is involved. NB. Focal disease affects only some glomeruli. Diffuse disease affects all the glomeruli. Segmental disease affects only part of the glomerulus. Global disease affects the whole glomerulus. Primary glomerular disease. Minimal change nephropathy. Etiology, pathophysiology, and pathology. The cause is unknown but is associated with atopy. The findings are as follows: light microscopy and immunofluorescence, normal or nearly normal. Electron microscopy, glomerular epithelial podocyte foot process fusion. Epidemiology. This disease constitutes 80% of childhood nephrotic syndromes and 25% of adult nephrotic syndromes, with an incidence of 2 per 100,000. The peak age of incidence is between 2 and 7 years, but all ages can be affected. Clinical presentation. Nephrotic syndrome often follows upper respiratory tract infection. In older people, minimal change disease may be associated with acute renal failure. Physical signs. Edema. Often facial swelling in children. Investigations. Urinalysis. Check nephrotic range in protein on 24-hour collection or check protein/creatinine ratio. Plasma. Check for hypoalbuminemia and hyperlipidemia. Renal biopsy. Children are often treated with a trial of steroids without a biopsy. Differential diagnosis. The differential diagnosis is from other causes of the nephrotic syndrome, especially focal segmental glomerulosclerosis, FSGS, and membranous nephropathy, amyloidosis, diabetic nephropathy, lupus and, rarely, congenital nephrotic syndrome. Treatment. Steroids. If there are frequent relapses or a poor response, then cyclophosphamide, cyclosporin, or tacrolimus can be useful. Diuretics for edema. Lipid-lowering drugs, usually statins, if there is prolonged nephrotic syndrome with hyperlipidemia. Penicillin prophylaxis may be given to prevent streptococcal infection. Complications. Complications are those of the nephrotic syndrome. Prognosis. Nearly all patients, 98% of children, 94% of adults, respond to steroids, 10 to 20% of these relapse several times, of whom 40 to 50% relapse frequently. Disease associations. Lymphoma. NSAID use. Focal segmental glomerulosclerosis. Etiology, pathophysiology, and pathology. This is of unknown etiology, apart from rare familial cases due to mutations in defined genes, NPHS2 encoding podocin, ACTN4 encoding actine N4, and TRPC6 encoding a cation channel. Minimal change nephropathy and FSGS share similarities and may be different points on a spectrum of disease. Damage to the glomerular filtration barrier causes protein leak and nephrotic syndrome. The findings are as follows. Light microscopy, focal and segmental glomerular sclerosis. Immunofluorescence, IgM and C3 in scars. Electron microscopy, glomerular epithelial podocyte foot process fusion. Epidemiology. FSGS accounts for 15% of adult nephrotic syndrome. It is also a common finding in individuals with non-nephrotic proteinuria and can occur if there is hyperfiltration due to any cause. Clinical presentation. Clinical presentations may include proteinuria, nephrotic syndrome, hypertension, chronic renal impairment. Physical signs. Hypertension. Edema if nephrotic. Investigations. Urinalysis, protein with or without blood. Plasma, hypoalbuminemia and renal impairment. Renal biopsy. Differential diagnosis. The differential diagnosis is from other causes of nephrotic syndrome or renal impairment, if present. Treatment. Steroids will induce a remission in many nephrotic individuals with FSGS, but the time to remission is longer than in minimal change disease. Cyclosporin or cyclophosphamide may be beneficial. Symptomatic treatment, diuretics, angiotensin-converting enzyme, ACE, inhibitors or angiotensin receptor blockers to control BP and reduce proteinuria, and lipid-lowering agents if required. Complications. Complications are those of the nephrotic syndrome and chronic renal impairment. Often recurs in transplanted kidneys. Prognosis. Between 40 and 60% of patients develop end-stage renal disease within 10 years of being diagnosed with FSGS. Up to 40% of both adults and children remit in response to steroids. Those who do respond have a much better prognosis for renal survival. Disease associations. FSGS is associated with obesity, and also occurs at increased frequency in Black ethnic groups, those who are infected with HIV and in intravenous drug users. Membranous nephropathy. Etiology, pathophysiology, and pathology. The etiology is unknown. Damage to the glomerular filtration barrier causes protein leak and nephrotic syndrome. The findings are as follows. Light microscopy. Thickening of the glomerular basement membrane, GBM. Immunofluorescence, immunoglobulin and complement deposition. Electron microscopy, subepithelial membrane deposits. Epidemiology. This is the most common cause of nephrotic syndrome in older patients in the UK. The peak age is 30 to 50 years. Clinical presentation. Clinical presentations may include nephrotic syndrome, chronic renal impairment, asymptomatic proteinuria, hypertension. Physical signs. Edema if nephrotic. Hypertension. Investigations. Urinalysis, protein with or without blood. Plasma, for signs of hypoalbuminemia and renal impairment. Renal biopsy. Differential diagnosis. The differential diagnosis is from other causes of nephrotic syndrome or renal impairment, if present. Exclude systemic lupus erythematosus, SLE. Treatment. Symptomatic treatment, diuretics, ACE inhibitors to control BP and lipid-lowering agents. Steroids and chlorambucil or a calcineurin inhibitor may be effective in those who are severely nephrotic or have declining renal function, but these agents are not used unless membranous nephropathy is causing such problems. Complications. Complications are those of the nephrotic syndrome or chronic renal impairment, if present. Prognosis. Between 20 and 30% of patients remit spontaneously, 40% have a partial remission or remain stable, and around 30% develop progressive renal failure. Disease associations. Hepatitis B. Malignancy. SLE. Drugs and toxins, gold, penicillamine, and mercury. IgA nephropathy. Etiology, pathophysiology, and pathology. The etiology is unknown, but it is associated with abnormal glycosylation of the hinge region of bone marrow-derived IgA. Renal IgA deposition may trigger complement-mediated damage. The findings are as follows. Light microscopy, mesangial matrix expansion and mesangial cell proliferation. Immunofluorescence, IgA deposits in mesangium. Epidemiology. IgA nephropathy is relatively common. The prevalence of overt nephropathy is approximately 2 per 10,000. The peak incidence of IgA nephropathy is in the second and third decades. The male-to-female ratio is 3.6:1. Post-mortem studies reveal mesangial IgA deposits in as many as 2–5% of all individuals, i.e. IgA deposition is much commoner than overt nephropathy. Clinical presentation. There may be macroscopic hematuria at the same time as, or 1 to 2 days after, a sore throat, synpharyngitic. Most patients will have microscopic hematuria. Hypertension is common and there may be renal impairment. There may be a vasculitic skin rash, Hainoxian line purpura. Less common presentations include nephrotic syndrome, in 10% of cases, and, rarely, acute nephritis. Physical signs. Hypertension. Investigations. Urinalysis, blood and protein. Plasma, for renal impairment, serum IgA is raised in 50% of cases. Renal biopsy. Differential diagnosis. The differential diagnosis is from other forms of glomerulonephritis, e.g. SLE, post-streptococcal glomerulonephritis, and antineutrophil cytoplasmic antibody, ANCA, associated vasculitis. Treatment. The role of specific treatment is unclear. However, strict BP control, typically with ACE inhibitors or angiotensin receptor blockers, reduces the risk of progression of renal impairment. Hypercholesterolemia should be controlled with statins. There is likely to be a small benefit from fish oils, although this is controversial. Also remember the following. Steroids may be given if nephrotic. Aggressive disease with crescent formation may be treated with steroids, cyclophosphamide, or mycophenolate mofetil. Symptomatic treatment should include diuretics, ACE inhibitors to control BP and lipid-lowering agents. Prognosis. Highly variable. Ranges from spontaneous clinical remission to rapid progression to end-stage renal disease. 15% of patients develop end-stage renal disease within 10 years of diagnosis, 20–30% by 20 years. Complications. Complications are those of the nephrotic syndrome, chronic renal impairment and hyperlipidemia if present. Disease associations. Liver disease, alcoholic and viral hepatitis, HIV, celiac disease, mesangiocapillary glomerulonephritis, membranoproliferative glomerulonephritis. Etiology, pathophysiology, and pathology. The etiology is often unclear. If cryoglobulinemia is present, hepatitis C is often the underlying cause. Rarely there is an autoantibody resulting in complement activation, C3 nephritic factor. The disease is subclassified into types I and II. Type I is usually associated with SLE, infection, or cryoglobulinemia. The findings are as follows. Light microscopy, types 1 and 2 show mesangial expansion and mesangial cell proliferation, also thickening of the GBM. Immunofluorescence, type 1, immunoglobulins and complement, type 2, some C3. Electron microscopy, type 1, subendothelial deposits, type 2, intramembranous deposits and subepithelial deposits. Epidemiology. The disease is declining in developed countries, and 80% of the cases that do occur are of type 1. It accounts for 10–20% of biopsies performed for presumed primary glomerulonephritis. Clinical presentation. Presentation varies from asymptomatic hematuria or proteinuria to acute nephritis or severe nephrotic syndrome. Physical signs. Hypertension, edema. Investigations. Urinalysis, blood and protein. Plasma, renal impairment, hypoalbuminemia and low complement levels, especially C3. In type 2 disease there may be antibodies to the C3 convertase C3BBB, resulting in complement activation. Renal biopsy. Differential diagnosis. The differential diagnosis is from other causes of chronic renal impairment and of nephrotic syndrome, if present. Both post-infectious glomerulonephritis and SLE also cause renal disease and hypocomplementemia. Treatment. Treat any underlying cause. Although steroids and cytotoxic agents have been used, their benefit has not been proved in adults. Symptomatic treatment, diuretics, ACE inhibitors to control BP and lipid-lowering agents. Complications. Complications are those of the nephrotic syndrome or chronic renal impairment, if present. There is a high recurrence rate following renal transplantation. Prognosis. Half of all patients develop end-stage renal disease within 10 years of diagnosis, 90% develop it by 20 years. Disease associations. Infection, especially with hepatitis B and C viruses. Autoimmune disease, especially SLE. Complement deficiency, partial lipodystrophy is associated with type 2 disease. Hypogammaglobulinemia. Diffuse proliferative glomerulonephritis. Acute endocapillary glomerulonephritis. Etiology, pathophysiology, and pathology. This may be idiopathic or secondary to infection, typically post-streptococcal, but also in the context of chronic infections. The findings are as follows. Light microscopy, endothelial and mesangial cell proliferation, and glomerular infiltration with neutrophils and monocytes. Immunofluorescence, complement and immunoglobulins. Electron microscopy, subepithelial deposits. Epidemiology. This disease is declining in developing countries. The peak age of incidence is 2 to 12 years, and the male-to-female ratio is 2:1. It accounts for 10% of glomerular disease in developed countries and is the most common histological presentation of intrinsic renal disease in developing countries. Clinical presentation. Presentation is typically 1 to 2 weeks after a streptococcal throat infection or 3–6 weeks after a streptococcal skin infection. It varies from asymptomatic microscopic hematuria to acute nephritic syndrome with frank hematuria, edema, hypertension, and oliguria. Physical signs. Hypertension. Edema. Signs of preceding infection. Investigations. Urinalysis, blood, all cases, sometimes protein, and often red blood cell casts. Plasma, impaired renal function, serological evidence of infection such as raised anti-streptolysin O titers and anti-DNase B. Also low complement levels, especially C3. Differential diagnosis. Mesangiocapillary glomerulonephritis. SLE. Treatment. Ensure that any focus of infection is eradicated, using antibiotics and surgery. Symptomatic treatment, diuretics, hypertension, ACE inhibitors, and lipid-lowering agents. Complications. Complications are those of the ongoing infection, uncontrolled edema, or hypertension. Prognosis. Good, only 0.1 to 1% of patients have progressive renal impairment. Antiglomerular basement membrane disease. Goodpasture's disease. Etiology, pathophysiology, and pathology. Autoantibodies to the basement membrane in glomeruli and alveoli cause renal and pulmonary damage. The antigen is usually part of the non-collagenous domain of the 3-component of type 4 collagen. The signs are as follows. Light microscopy, focal segmental proliferative glomerulonephritis, often with necrosis and crescents. Immunofluorescence, antibody deposition, usually IgG, along the GBM. Epidemiology. Rare, 0.5 to 1 per million per year. It occurs mainly in white patients, and in more men than women. Clinical presentation. The presentation is with lung hemorrhage in 50 to 70% of patients, causing cough, hemoptysis, or shortness of breath. Renal involvement is initially asymptomatic, but can cause loin pain, frank hematuria, oliguria, and acute renal failure. Physical signs. Lung signs resemble pulmonary edema or infection. Investigations. Urinalysis, blood and protein, and red cell casts. Plasma, renal impairment and anti-GBM antibodies. CXR, diffuse pulmonary hemorrhage may resemble pulmonary edema or infection. Lung function, gas transfer, KCO, is raised by the absorption of carbon monoxide by the blood in the alveoli if hemorrhage has occurred recently. Renal biopsy, Differential diagnosis. Systemic vasculitis. Another glomerulonephritis with pulmonary edema or infection. Treatment. If the patient's kidneys have not failed completely, do the following. Plasma exchange is used to remove the pathogenic antibody. Immunosuppression with steroids and cyclophosphamide is used to inhibit further antibody production and reduce inflammatory damage. Azathioprine may be substituted for cyclophosphamide in the later stages of treatment. If the patient requires dialysis at presentation, then most nephrologists would not give immunosuppression. Complications. Respiratory failure, secondary pulmonary infection, and treatment toxicity. Prognosis. Untreated, most patients die. Patients who require dialysis before treatment is started do not usually recover. Renal function and morbidity from immunosuppression is high, if it is given at all. Of those patients whose plasma creatinine is below 600 moles/L before treatment, 80 to 90% recover independent renal function. Disease associations. There is a strong association with human leukocyte antigen, HLA, DR15 and a weaker association with HLA-DR4. Pulmonary hemorrhage is more common if the patient is a smoker, has pulmonary infection or edema, or there is exposure to other inhaled toxins. Crescentic glomerulonephritis. Rapidly progressive glomerulonephritis. Focal necrotizing glomerulonephritis. Renal microscopic polyangiitis. Etiology, pathophysiology, and pathology. The etiology varies. The findings are as follows. Light microscopy, proliferative glomerulonephritis with fibrinoid necrosis, often with crescents, inflammatory cells in Bowman's capsule, and possibly small vessel vasculitis. Immunofluorescence, see below. This condition is subclassified as follows. Anti-GBM disease. Renal microscopic vasculitis, immunofluorescence shows scant or absent immunoglobulins. Serum ANCA is usually positive and there may or may not be extrarenal manifestations. Complicating a pre-existing glomerulonephritis, a systemic disorder or an infection, immunofluorescence often shows immunoglobulin deposition. Associations include lupus, Hainoxian line purpura, IgA nephropathy, mesangiocapillary glomerulonephritis, and post-infectious glomerulonephritis. Epidemiology. Accounts for 2 to 5% of renal biopsies. The male-to-female ratio is 2:1. Clinical presentation. Renal disease is often asymptomatic but can result in oliguria and acute renal failure. Manifestations of associated or underlying systemic diseases may be present. There may be systemic symptoms such as fever, weight loss, and general malaise. Physical signs. Manifestations of systemic disease may be present, such as rashes or joint lesions. Investigations. Urinalysis, blood, protein, and red blood cell casts. Plasma, renal impairment, raised inflammatory markers such as C-reactive protein, erythrocyte sedimentation rate, white cell count and platelet count, positive serological tests for associated systemic diseases, especially ANCA or anti-GBM antibody. Renal biopsy. Differential diagnosis. Other forms of acute glomerulonephritis. Other causes of acute renal failure. Treatment. Immunosuppression with prednisolone and cyclophosphamide. Azathioprine may be substituted for cyclophosphamide after 3 months. Plasma exchange is used for anti-GBM antibody disease. Therapy for rapidly progressive glomerulonephritis is often supplemented with adjuvant methylprednisolone or plasma exchange. Complications. Complications are those of immunosuppression and acute renal failure. Prognosis. Less than 25% of patients escape dialysis, but, with treatment, the 5-year survival rate once off dialysis is 60 to 80%.